Hello dear friends and colleagues, today I'd like to talk about another important topic which is very common in your practical life and in an exam. So I'd like to discuss in short in exam point of view so that you can answer all related question. Uh, so let's start. It is motor neuron disease. By the name of the disease you can guess where is the problem. Motor neuron disease, there is a problem in the motor neuron, not in sensory neuron. So there will be no sensory involvement, only motor involvement. Cause we don't know. So there is no known cause, but there are some predisposing factors or some familial association, 5 to 10%. Somebody say that it is maybe due to post viral infection, or maybe due to toxin or electric shock or traumatic, but exact cause is not known. There are some superoxide dismutase 1 enzyme defect also. Somebody says okay, there are some problem in glutamate receptor, it increase and it causes continuous stimulations of motor neuron, and that cause the damage of the motor neuron. For that reason it happened, but exact cause is not known. There are some no in motor neuron disease. Let's learn that. First I told that there is no sensory involvement, no known cause, no sphincter involvement except in the later stage, no cerebellar or extrapyramidal involvement, no dementia, but in later stage can be, no alterations of the mental status, that is in the at the end of the life of the patient, mental condition will be preserved. So there are some no ocular involvement, that extraocular muscle will not involve. So as there is no cause, so there is no treatment. So this you have to remember this no sensory involvement, no known cause, no treatment, no sphincter involvement, no cerebellar or extrapyramidal involvement, no dementia, no extraocular muscle involvement, and no alteration of the mental status at the end of the life. Okay. Now just we know that motor system, the motor neuron, where actually it located in the motor cortex, we know, and in the anterior horn of the spinal cord, and in the brain stem. So you just if categorize upper motor and lower motor. So in the motor cortex, the upper motor neuron, and in the spinal cord and the brain stem is lower motor. So this involvement, both of involvement can cause upper motor and lower motor problem. Let us see. Upper motor, in the cerebral cortex, the involved cell is base cell, that is a motor neuron, and so base cell involvement, base cell damage, it is progressive, it cause problem of the upper motor neuron type of lesion symptoms, and in the brainstem and spinal cord it will cause lower motor neuron type of problem or symptoms. So would like to know now upper motor and lower motor, how will manifest it. Upper motor and lower motor both can cause loss of power, that is weakness. So both can cause weakness. Then tone, you just remember in upper motor neuron lesion everything will be upper, that means more increased, and in lower motor neuron everything will be decreased. So, upper motor neuron, if we see the tone, it will be increased. So, patient may present with spasticity, and lower motor neuron it will be decreased. Upper motor neuron jerk will be exaggerated, increased again upper, and lower motor neuron the jerk will be less or absent. Upper motor neuron, the plantar extensor will be there, so there will be extensions of the great toe, that means upper increased, and lower motor neuron there will be flexion, that is lower. In upper motor neuron layer there will be no fasciculation, but lower motor there will be fasciculation and wasting of the muscle in the lower motor neuron. In upper motor neuron there will be no wasting of the muscle, but in the long term, in the chronic disease, there will be disease atrophy. So, there may be some wasting in upper motor neuron. So, in the motor neuron disease, you will get different form of this involvement, maybe combination of upper and lower motor neuron, maybe only upper motor neuron or only lower motor neuron, or in the involvement of the brainstem. So, let us see the type. When only upper motor neuron lesion, symptoms will get predominantly, it is primary amyotrophic, it is primary lateral sclerosis, and if only lower motor neuron type, then it is called progressive muscular atrophy. Just remember, progressive muscular atrophy means progressively, this disease is progressive. So, progressive and muscular atrophy, in lower motor neuron there will be atrophy of the muscles. So, it is predominantly lower motor type, for that reason there is atrophy. So, progressive muscular atrophy, one kind of motor neuron disease, and primary lateral sclerosis, the motor predominant, another type. And when this upper and lower motor both mixed, then it is called amyotrophic lateral sclerosis. This is the most common type. You can say more than 75 to 85% of cases you will get amyotrophic lateral sclerosis. That is the combinations of the upper motor and lower motor. Okay. Now there are another type, the last type, fourth one is bulbar involvement. So, bulbar or pseudobulbar type. Bulbar involvement, bulb means medulla. So, there are 4 pair of nerves in the medulla, 9, 10, 11, 12. This is the bulbar involvement. So, this bulbar involvement means the nerve fibers of the medulla will be involved, the nucleus of the medulla, the cranial nerve. It is lower motor neuron type. But pseudobulbar means the involvement is not in the bulb, that is not in the medulla, it is in the cortex, motor cortex. Motor cortex, those fibers supply to the bulb, that is corticobulbar nerve involvement. This is pseudobulbar. So, it is upper motor neuron type. So, there are 4 types. One is most common type is amyotrophic lateral sclerosis, which involve both upper and lower motor. Then predominantly motor, that is primary lateral sclerosis, predominantly lower motor neuron type, that is progressive muscular atrophy, and another one is bulbar involvement, pseudobulbar and bulbar type motor neuron disease. Okay, 4th type, and I already mentioned the location where is the problem also. Now, if amyotrophic lateral sclerosis, how will present the patient? There will be both combinations of upper motor and lower motor neuron, and interestingly, in the lower limb, in amyotrophic lateral sclerosis, you will get the upper motor neuron type lesion more than that of lower motor neuron type. So, flexor muscle group will be involved more, and in the upper limb, the lower motor type involvement is predominant than upper motor neuron. So, the muscle wasting will be more here. Okay, just remember this. and you will get the upper and lower motor combination, symptoms of combination. For example, spasticity may be there, or there will be muscular bursting, which is symptoms of lower motor neuron type, and knee jerk will be present, ankle jerk absent, and you will get plantar extensor. So, absent ankle jerk, plantar extensor, this is the combination of both upper and motor neuron, lower motor neuron type. There will be fasciculation, there may be fasciculation also. So, this type of symptoms you will get, spasticity, combinations of exaggeration of jerk, absent of jerk. So, this type of thing, but there will be no sensory involvement. This is amyotrophic lateral sclerosis. In the upper limb also you will get combinations of upper and lower motor neuron, muscle bursting, this type of thing will get. And as this involvement, the nerve involvement is diffuse, so you will get both limb together, both upper and lower limbs. So, there will be quadriplegia, quadriparesis like that. So, symmetrical involvement will be there. Now, in this regard, actually I would like to mention some causes, other causes. You have to think that when there is extensor plantar and absent ankle jerk, there are other causes also. Number one, motor neuron disease, already I told, and number two, subacute combined degeneration of the cord, multiple sclerosis, then one genetic disorder, that is Friedreich's ataxia. Another one is taboparesis, Conus medullary syndrome, then syringomyelia, then in cervical myelopathy, and any upper motor neuron type of lesion with combinations of peripheral neuropathy. You will get extensor plantar with absent ankle jerk. Just remember, it is the DD, but in motor neuron disease will not get any sensory involvement or other involvement. Okay. Now, bulbar involvement or pseudobulbar involvement. Bulbar involvement involve 4 pair of cranial nerve, 9, 10, 11, 12. So, 9 mean glossopharyngeal, 10 vagus, 11 accessory nerve, and 12 hypoglossal nerve. Hypoglossal nerve supply all the nerves of the tongue, all the muscles of the tongue. So, you will get the if bulbar involvement, lower motor neuron type. So, there will be wasting, there will be fasciculations in the tongue, and as lower motor neuron type, there will be weakness of the tongue. So, articulation, phonation because of involvement of the pharynx and palate, there will be problem in the phonation. So, dysphonia, dysarthria and dysphagia will get, and slurred speech. Okay. Another thing, when it is pseudobulbar, that is the upper motor neuron type. So, in that case you will get small tongue, there will be no wasting, but there will be spasticity of the tongue, and patient will have nasal voice. So, just remember, in the in your childhood probably you will have experience of cartoon Donald Duck. So, this type of nasal voice you will get in case of pseudobulbar involvement. And as there is a problem of this deglutition, there will be chance of aspiration. So, aspiration pneumonia, one of the complications of the bulbar or pseudobulbar involvement. Okay. Now, amyotrophic lateral sclerosis, bulbar, pseudobulbar, these two types already finished. Third type is primary lateral sclerosis. It is motor upper motor neuron type predominant. So, we will get the upper motor type of symptoms like spasticity, weakness, exaggerated tendon reflex, something like that. And in the another one of progressive muscular atrophy, you will get the lower motor neuron type operation, already I mentioned. Okay. Another thing actually we have to remember that the all motor neuron disease will involve the diaphragm. The main respiratory muscles will involve. So it will be the weak. So there will be respiratory problem, respiratory failure will be there, and the most of the patient will die in respiratory failure. Okay, and aspiration pneumonia is complication because there is a problem in deglutition. So the aspiration is one of the complication which will reduce the lifespan of a patient. So it is, just remember, the bulbar and pseudobulbar type involvement of the motor neuron disease is the worst prognostic. And as the progressive muscular atrophy, that means the atrophy of the our limb, if you don't have limb, you can survive. That means the prognosis is very good for the lower motor neuron type, that is progressive muscular atrophy. This is the best type for perspective of patient prognosis. Now, male predominant, actually I would like to say that this motor neuron disease is common in male and around 40 years of age. Below 30 will not get. Okay. Now, how will you diagnose the case? Diagnosis is clinical, just remember it. You have to diagnose is clinical. Upper motor, lower motor combination, there is no sensory involvement, around age 40 years, male person, you can say that it's a motor neuron disease, but you have to exclude other disease also. So how will exclude? You do EMG, electromyography. So in EMG what will get? Because there is problem in the motor nerve system, it is responsible the muscle contraction, there will be no contraction or defective contraction. At the same time, in resting phase there should not be any contraction or any stimulation or any action potential, but in case of motor neuron disease you will get spontaneous contraction, spontaneous action potential of the muscles, but it is not exclusive. You need the clinical correlation. Another one, nerve conduction study to see whether there is any problem in the nerve or not, any peripheral neuropathy or any other things or not. Another investigation you can do to exclude other disease in the brain. So MRI can be ordered to exclude other disease. So basically in exam they will ask EMG finding. So there will be in EMG finding you can get spontaneous contractions of the muscles. Okay. Now what will be the treatment? There is no cause, so there is no treatment, no cure. After diagnosis of the patient, within 3 to 5 years patient will die, unfortunately. Some patient may survive up to 10 years. Okay. So if there is no treatment, it is very difficult to approach to the patient. So what we have to do? Patient education, counseling, explanations of the condition, that this disease is not curable, but we can do lot of things. What are those? Multidisciplinary team approach. One thing is physiotherapy. Why? Because to prevent the muscular atrophy by doing exercise of the joint, prevent the stiffness of the joint, physiotherapy, respiratory rehabilitation physiotherapy can be will be necessary, because there will be problem in respiration also. Occupational therapy. Occupational therapy, because patient is needed daily activities in his house, so the occupational therapist will arrange all the things which is easily accessible for the patient and which is easily he can do everything thing, for example washing, cooking or bathing, this type of thing patient can easily do. For that reason occupational therapist will arrange everything. Support group, because financial support is necessary for this patient, so we need to involve support group. Speech therapist, speech problem will be there, so speech therapist, language therapist will help this patient. There is no treatment, so respiratory physician also we need to involve. We need involvement of neurologist. Okay. Now, any pharmacological treatment? Yes, NICE recommend one medication, that is riluzole, which is glutamate antagonist, which can be used for only amyotrophic lateral sclerosis type of motor neuron disease. And after using 18 months, they found that patient survival span, that is lifespan, increased only 3 to 4 months. It is expensive, still the NICE recommend for every patient of amyotrophic lateral sclerosis. It will not stop the disease process, it will only increase the lifespan only for few months. Okay. Another intervention, that is non-invasive ventilation, has better outcome than that of riluzole. So we recommend non-invasive ventilation also. Okay. And preventions of the aspiration pneumonia. So nutrition is very important. We need to involve dietitian and PEG, that is percutaneous endoscopic gastrostomy, PEG feeding. And if any patient is having problem in the respiration, they cannot tolerate anesthesia, in that case radiologically guided gastroscopy can be tried. So nutrition also should be maintained by dietitian, and PEG can be inserted to feed the patient. And other symptomatic treatment, psychologist or psychiatrist can be involved, because patient may develop depression. So whatever necessary symptomatic treatment is necessary for the patient, so all the symptomatic treatment will be ensured